Visual acuity. So people who are legally blind don't fall. You know, they've learned to compensate for their falls unless they become so blind they can't see anything, and it's overwhelmed the ability to compensate. People who tend to fall due to vision problems are people who've had a sudden vision loss, they've had a retinal tear, a stroke with hemianopsia, and they haven't learned how to compensate yet. People with vision problems can start falling if something else is going on, if they lose their cognitive ability to compensate for their vision problems. So they develop delirium or depression or dementia, and they no longer use their walker, they no longer avoid those dangerous stairs, they no longer do the compensatory measures. Once again, eventually the vision problems can become so severe that people can't compensate. So the common vision problems we all encounter are glaucoma. So in glaucoma, first you lose your peripheral vision, and it's like looking through a tunnel. Cataracts and age-related macular degeneration, where you lose your central vision. So you lose your cones. I remember CCC, cones, central, color, and cones. So you lose your color vision, which are your central cones. People with macular degeneration will start to look at you sideways, so they'll look at you with their peripheral vision using their rods, their peripheral rods. So they can see, if you look at someone beside you sort of sideways, you can see that they're there, you can see their face, but you can't really discriminate any facial expressions, you can't read writing. It's very, very gross vision. If you have someone with macular degeneration, just as an aside, who has a sudden vision loss, they say, my vision just changed this morning, you call their ophthalmologist right away, and you say, this is what happened. Invariably, they'll say, bring them down, there might be retinal tear, they might need laser therapy. That's an emergency, so they should go see their ophthalmologist immediately. E. Other neurological impairments. So now we're getting into areas that I do a lot of, and these are areas that blow up quite a bit, and it's incredible how much is in there. So the other neurological are almost anything. So the 3Ds, make sure it's not dementia, delirium, depression. How do dementia, delirium, depression cause falls? Number one, apraxia. In some types of dementia, like vascular dementia, you can hit the parietal lobes, you can have early apraxia. In Alzheimer's, in the medium to later stages, you'll develop apraxia. So you're not placing your feet where they should be, and then you start to fall. You see that in delirium. We see that in hospital quite a bit as people are recovering from delirium. I watch them working with the physiotherapist, and they're very apraxic. Their feet are not landing where they should. You know they're going to fall if someone's not holding on to them. Other things that can happen, as I said, decreased compensation. They're not using their walkers when they should. They're not doing the safety measures, and they're going in dangerous areas they wouldn't have before. And then in delirium and depression, slow mentation. They're not reacting as quickly as they could. Other things, neurological, very self-evident: stroke, subdural, subarachnoid bleeds, cerebellar disease, normal pressure hydrocephalus, spinal stenosis, myasthenia gravis, ALS, peripheral and autonomic neuropathy, and Parkinsonism. So how do I remember this? I just go from head to toe, and I try to imagine any neurological disease that can occur as you do cuts. So stroke, subdural, subarachnoid, normal pressure hydrocephalus, dementia, delirium, depression, vision, and I just slice the body, and I go through all the cuts, and that's how I remember things, because I could never memorize a list like this. And then if you do have someone who has Parkinsonism, if they have the slow resting tremor either in their hands or their chin or their feet, if they have slowness of movement, akinesia, bradykinesia, if they have cogwheel rigidity and falls, this is the differential that we go through. So the first is Parkinson's disease, what neurologists would call idiopathic Parkinsonism. So they have the TRAP, the motor symptoms, tremor, cogwheel rigidity, so the rigidity is kind of a ratchety motion like that, akinesia, bradykinesia, so they're slow, and postural instability, falls, which is how you might see them in this pilot. Some people will have vascular Parkinsonism. They have what looks like Parkinson's disease, but they're not responding to Cinemet. And what you see on the CAT scan is you see either multiple strokes all over the place, or you see strokes in the basal ganglia, the area that Parkinson's affects. I wouldn't jump to the diagnosis of vascular Parkinson's just because you see those strokes, because you'll see those strokes in people who are normal. It all depends on where they hit the basal ganglia precisely, and you'll see that in people with real Parkinson's. So I would assume it's Parkinson's disease first, and see if they can respond to Cinemet. Drugs. There are some drugs that cause Parkinsonism that we talked about, the antipsychotics, and the GI drugs, Stemetil and Maxran. So what do antipsychotics do? They push down dopamine, and they make you Parkinsonian. What does Cinemet do? Cinemet pushes up dopamine, and if you overdose on Cinemet, you're psychotic. So really, there's a spectrum of effect here, trying to get the right dopamine level that's not causing too much rigidity or psychosis. Lewy body disease or Lewy body dementia is the fourth type of Parkinsonism. So this is dementia. These people come in with hallucinations, fluctuations. So it sounds like delirium. When you hear hallucinations, fluctuation, that's delirium. But what they tell you is, yeah, mom's been having hallucinations. She's been seeing or hearing things that aren't there for 18 months. Then you go, it's hard to believe you'd be that delirious for that long. You really should be in the hospital if you're that sick. So then you think about things like psychotic disorders or Lewy body disease. People with Lewy body dementia or any of these really don't tolerate antipsychotics very well. So if they're on this list, I would avoid antipsychotics. In Lewy body dementia, the cholinesterase inhibitors really take away the hallucinations very well. And I should have given a disclosure at the beginning. I don't work for any for the pharmaceutical industry, and I don't take anything from them. So this is a sort of an independent opinion. Lewy body dementia is very, very responsive to the cholinesterase inhibitors. It doesn't seem to be helped very much with memantine. We'll often try memantine out of desperation, but the cholinesterase inhibitors do take away the hallucinations. And then progressive supranuclear palsy. So I see a lot of people around the table with glasses, and I've had glasses since I was 5. When you have glasses and you change your frames, and they're not the same size, sometimes you trip a little bit because the frame's not where you're used to having it. People with progressive supranuclear palsy have a similar problem. They lose their downward gaze, so they can't look down, and they present with falls. Eventually, they lose their upward gaze and then their lateral gaze. So they develop an ophthalmoplegia. They can't move their eyes. So just seniors in general, some seniors can lose their upward gaze in isolation. That doesn't mean anything. But if you lose downward first and then the others, then you have to really worry. So whenever you put in a consult to a neurologist for Parkinson's, what you really want to see is they evaluated the extraocular movements. That tells you they're working through a list including PSP. After the eye movements stop, people develop rigidity of the neck, rigidity of the trunk. So they look quite frozen. They can't move their neck or their trunk, and they can't move their eyes. They look very locked in. They develop a lot of depression, anxiety, psychosis, and dementia. It's a horrible, horrible disease. In a family practice of 1,500 to 3,000, you might have 2 or 3 people with PSP. It's a really, really a rough disease to have. Next is late Alzheimer's. It's someone you know has had Alzheimer's dementia for many years. They're in a retirement home, maybe looking towards long-term care, and you're starting to see a bit of a tremor. We don't tend to treat that. The drugs that are used for Parkinson's to prevent falls either increase dopamine, so they would cause psychosis in someone with Alzheimer's, or they're anticholinergic. And in Alzheimer's, we try to do the opposite. We try to push up acetylcholine. So we tend not to treat that. And then finally, the multisystem atrophies. So these are people, they look Parkinsonian, but when you look, they also have peripheral neuropathy, they have cerebellar signs, spinal cord signs, and as physicians, we don't know what's going on. We consult neurology, and neurology says, yeah, it appears multi-systems are affected. And the one that often comes into, not often, but that does show up in the internal medicine wards is Shy-Drager, because that has severe autonomic neuropathy, so severe blood pressure drops. So where do you go in the hospital when you have low blood pressure? You go to internal medicine, so they see Shy-Drager. The others are less common: olivopontocerebellar degeneration, striatal-nigral degeneration. It's just for you to be aware, there's a whole list of things that look Parkinsonian. So when people say there's Parkinsonism, it may not be Parkinson's disease, it may be one of these others. Neurologic impairment still, vertebrobasilar insufficiency. So the vertebral arteries run through the bones of the neck, through the cervical vertebrae, and in some people you can get bony growth, arthritis, that starts to impinge upon those vertebral arteries. So when people move their neck, either rotate their neck or more often look upwards, the vertebral arteries are pinched. And people start to become dizzy and they fall down. According to the textbooks, we're supposed to be seeing diplopia, dysarthria, facial numbness, and ataxia. Maybe the ataxia is the falls, but the rest of them I haven't seen. I'm still looking for that. A lot of people are given the diagnosis of VBI, or vertebral basilar insufficiency, who don't have it. There's something else going on. It's just kind of a speculative or working diagnosis. So when you see that, be a little bit wary. Sometimes when we do the carotid artery Dopplers, they will look at the vertebral arteries and tell us whether they're stenotic or not. So they can be looked at with ultrasound. And the treatment for that is behavioral modification. If you get dizzy looking up, stop looking up. So that, there's no surgery that can open up all those framens. Vertigo. So this is the normal algorithm I do in my talk when I go through falls. I do vertigo first, and then I do everything else I've been talking about. I decided not to put vertigo into this talk. You should be aware vertigo is a cause of falls. My sense is, and you can correct me at the end, and if we have time, I do have slides I can go through, but my sense is that primary care is much better at evaluating vertigo than I am or than any specialists are, except for maybe ENT, because primary care sees a lot more vertigo. By the time they get to specialists, the peripheral causes are gone. The people have recovered. It's central vertigo, and then we refer on to ENT anyways. So I'm not going to get into this unless there's a rebellion at the end and you insist we go through it. But I think you'll be pretty tired by the end. So I don't anticipate that. But it is there. Vertigo is not in the American British Geriatric Society list. And it should be there because it certainly can cause falls. Heart rate and rhythm. So in my mind, I try to simplify things. Essentially, what causes a decrease in cardiac output? Category 1, things that block the blood from flowing to the brain. Number 2, arrhythmias, so things that change the beating of the heart so it doesn't pump enough blood. And number 3, a heart that just can't beat anymore. The myocardium is not good enough to push blood. So blocking blood flow, as I said, I'm very simple. Aortic stenosis. We always listen for aortic stenosis murmur. Mitral stenosis. As I said, if you have aortic stenosis and you're starting to have syncope falls, you're in the last few years of life unless you get surgery. Subaortic stenosis, so enlarging of the myocardium under the aortic valve. Aortic dissection, so a dissection within the aorta itself that's starting to plug the lumen, the space within the aorta. And pulmonary embolus, so a big clot in the lungs that's preventing blood flow going from the right side of the heart to the left side of the heart. So these are, and I could probably put carotid stenosis in there too. So these are things that are blocking blood flow from going through the heart and up to the brain. Next is arrhythmias, the actual beating of the heart. So tachycardia, so VTach, supraventricular tachycardia, Wolff-Parkinson-White ventricular fibrillation, rapid atrial fibrillation. How does a fast heart cause decreased cardiac output and dizziness? Well, for a heart to function properly, think of it like a bellows that you would use on a fireplace. What the heart has to do, it has to relax and has to open up and accept a full volume of blood, and then it contracts and it pushes out that blood. So there's a bellows mechanism. There's a certain amount of time that's required for that left ventricle to open up and completely fill up. If your heart's going too fast, over 150, the heart's not opening all the way before it has its next beat. So you're not getting the full volume going through. So that's really helped me understand how tachycardia decreases cardiac output, because you'd think the opposite, right? You'd think, well, it's going faster, it should be moving a lot more blood, but it's just not allowing the heart to fill up. Bradycardia, slow heart rate, is much easier to understand. So sick sinus syndrome, conduction blocks. Certainly if someone has a very low heart rate, you're going to be doing ECGs and deciding, do they need a pacemaker? And we do see that quite often. And we have a lot of people come through for assessment of falls, and what they have is intermittent complete heart block. And then they go for a pacemaker and they're cured. Make sure they're not on a medication that can slow the heart. So digoxin, beta blockers, including the Timoptic or Timolol eye drops. In some people, those are systemically absorbed. Alzheimer medications, the cholinesterase inhibitors, they increase acetylcholine. What does the vagus nerve do? The vagus nerve that can slow the heart down, it increases acetylcholine. So you're essentially increasing vagal stimulation. So the cholinesterase inhibitors can cause sinus bradycardia, but they can also block the AV node, so AV conduction. So they can cause a lot of problems with cardiac conduction and cardiac pulsing, and that's why we don't use them without an EKG. Even with a normal ECG, somebody may be 3 months away from their first sick sinus syndrome, their first very low heart rate, and we give them a stress test, and then we find out what's going to happen in a few months. And then the calcium channel blockers. So if they're on these medications and the heart rate is slow and they're getting dizzy and falling, think about these medications. And then carotid sinus hypersensitivity, where you touch the carotid artery, the carotid sinus, and people become bradycardic and start falling down. I'll be honest, I haven't seen that. So maybe I haven't been looking hard enough. It's in the American Geriatric Society and British Geriatric Society guidelines. It's mentioned very prominently, which I find strange because it's not a common etiology. And then very low ejection fraction. As I said, the heart should be, if it's fully expanded, pumping out 55% of its volume. 40 to 55% is mildly decreased. 20 to 40 is moderately. Less than 20 is severe impairment. So if they're less than 20, they're really not moving enough blood. They're just pushing out 20% of their volume of their left ventricle each beat. So you can't expect them to have much of a heart rate. And then vasovagal syncope. So this is the classic fainting, right? The first time you watched surgery, you passed out, or you had a friend who passed out, or they watched a scary movie on TV and they passed out, or they saw blood and they passed out, or they gave blood and passed out. Big emotional upsets. What happens is it increases the firing in the vagus. The vagus slows the heart down too much. Blood isn't moved, so blood doesn't get to the brain and they pass out. You'll see this with urination or defecation, so they can have a vasovagal, or swallowing or coughing. So often when seniors pass out in the washroom and they go to the emergency department, if there's no rhythm on the strip at that time, they can't say they had an arrhythmia, so they say it's a possible vasovagal. Be aware that's just a working diagnosis. You know, when you're trying to evaluate, if you're not measuring the rhythm at the time of the event, you really can't tell what's going on. So much like I said, vertebrobasilar is a working diagnosis, beware. Vasovagal is a working diagnosis, beware. It's often not the true diagnosis.